Hi, this is Amar Abdelgawad from Texas Tech El Paso. We're going to speak today about Intoeing. What are the objectives from this lecture? First, we'd like to identify the normal rotation of the lower extremity, and then we'd like to differentiate between physiologic and pathologic rotation of the extremity, and finally, we'd like to discuss common causes of intoeing of the lower extremity. A good source that you can use to read more about this topic is the book named Pediatric Orthopedic, a handbook for primary care physicians. It's written by myself and Dr. Naga. Let's discuss what is the definition of intoeing. What does it mean, intoeing? Intoeing means when the child walks, the feet will be turned inward instead of pointing straight ahead. It's commonly referred as being pigeon-toed, and this is one of the most common reasons for visit to the pediatric orthopedic. And as we're going to see, most of the cases of intoeing are actually normal development, and these cases do not have to be referred to the orthopedic surgeon. This is a nice video that will show us the intoeing. If you see this girl, she's walking forward, and despite she's walking forward, if you see the axis of her foot, it's pointing inward for about like 35 degrees. Let's repeat the video to see it again. So you see that her right and left side, the foot, are pointing inward about 30 degrees compared to the axis that she's walking, which is from along the hallway. Again, this is another picture for her. So let's discuss now what are the causes of intoeing. There are three main causes that will cause the child to have intoeing. First, the first cause is coming from the femur, which is excess femoral anteversion. The second cause is coming from the tibia, which is internal tibial torsion. And the third cause is coming from the foot, which is metatarsus adductus. So three etiologies that can cause intoeing: one in the femur, excess femoral anteversion; one in the tibia, internal tibial torsion; and one in the foot, which is metatarsus adductus. Now we're going to discuss these in more details. So first of all, let's see how are we going to evaluate a child who is coming with intoeing. So first thing is the foot progression angle. The foot progression angle is assessing the angle of the foot in relation to the axis of the walking of the child. And it is the first thing that you have to do when the family bring a child with the diagnosis of intoeing. Because it allows you to see if this child is really intoeing or not. So you ask the child to walk in the hallway, and then you see the relationship of his foot to the long axis of the walking. Is it outward external or inward internal, as we saw in the video before, and as we're going to see the video again to show you her foot progression angle. Remember, some kids don't walk normal in front of the doctors, so in order to distract them, you have to ask them to go many times back and forth, or you can ask them to run. And an important thing to notice in this case is don't do the foot progression angle in the room, do it in the hallway outside, because in the room you won't have enough space to assess the foot progression angle. So let's see the foot progression angle of this girl, the video that we saw before. So that's her long axis of walking, which is the axis of the hallway, and this is her axis of the foot. So the foot progression angle for her case will be -30. So again, this is the long axis of the hallway and the long axis of her walking, and this is the axis of her foot while walking. So this is internal by about 30 and 35 degrees. So second step after assessment of the foot progression angle is assessment of the hip rotation. Assessment of hip rotation is done as we see in the prone position. So as we're going to see later on, the second, third, and fourth step of the assessment of the rotation of the lower extremity is done while the patient is prone. So patient is prone on the table, and then the physician is going to assess the hip internal rotation and hip external rotation. As you can see here, a hip internal rotation is done by moving the foot or turning the foot outwards, because when you turn the foot outwards, you're actually turning the hip inward. And then assessment of the hip external rotation is done by bringing the foot inward, because when you bring the foot inward, you're actually bringing the hip outward. We have some clinical pictures later on in this lecture that will show that very clearly. So second step in assessment of rotation, is going to be assessment of the hip rotation to detect if the patient has excess femoral anteversion or not. And this is going to be done while the patient is prone. Both sides has to be done together, because if you do only one side, you may have movement of the pelvis instead of movement of the hip itself. So the physician is going to put the patient prone, hold both feet together, move the feet outwards so he can assess the hip internal rotation, and then move the feet inwards so he can assess the hip external rotation. Normal values is that hip external rotation should be equal to internal rotation or a little bit more. If hip internal rotation is much more than hip external rotation, that tells you that this patient most probably has excess femoral anteversion. We will see some pictures later on in this lectures about this condition. The third and fourth step in the assessment of the lower extremity rotation is assessment of the tibia and the foot. So again, the patient is prone. We did the second step, which is the assessment of the femur rotation by bringing the feet inward and outward. The third step is assessment of the tibia. We assess the tibia by what's called the thigh-foot axis. It means that we would like to see the relationship between the ankle and the foot on one side and the thigh on the other side. As we know, the tibia is the connection between the ankle and the thigh. So when we assess the thigh-foot ankle, we're actually assessing the rotation of the tibia. So again, patient should be prone. The physician is going to look from above and see the relationship between the foot and the ankle on one side and the thigh on the other side. There should be mild external rotation of the thigh-foot ankle. If there is internal rotation, that tells you that the tibia is turned inward, or what's called internal tibial torsion. Again, we're going to discuss that in details later in this lecture, and there is some pictures to show that easily. Fourth step is going to be assessment of the relationship between the forefoot and the hind foot. So let's So after we finish the assessment, let's now go for the causes of intoeing again. As we said, there's 3 causes for intoeing. 3 things that can cause the child have his foot turned inward while he's walking. First, if it's coming from the hip, we call that excess femoral anteversion. Second thing, if it's coming from the tibia, we call that internal tibial torsion. And third thing, if it's coming from the foot, we call that metatarsus adductus. We're going to discuss each of these now in details. So first thing is excess femoral anteversion. First, I'd like to define what does it mean femoral version. Femoral version is the angle between the femoral neck and the shaft in the sagittal plane. So this is a model of a femur on a flat surface. However, you'll see that the femoral neck, which is this part, and the femoral head, which is this part, are not lying on that flat surface. Why? Because the femoral neck has an angle with the sagittal plane of the femur. It means it has an angle with the plane of the femur when you look to the patient from the side. So this is the plane of the femur. When you see the patient from the side, it is the same plane as that flat surface, and the angle between the femoral neck and that flat surface is called the femoral version. So this angle usually at birth is about 40 degrees, and when we start walking, this angle decreases gradually, and it usually reaches the adult value, which is around 17 by the age of 8 years. That's why when you have diseases that affect the child's ability to walk, like cerebral palsy or spina bifida, usually these children continues to have a high femoral anteversion. So excessive femoral anteversion is the commonest cause of intoeing between the age of 3 to 8 years. So if you get a child about 5 or 6 year old, the parents bringing him because he has intoeing, the most common cause is excessive femoral anteversion. And as we discussed before, there is 4 steps in the assessment. First one is the foot progression angle. You'll see that he's really intoeing. And then the second step is the step which will show the excessive femoral anteversion, because the second step is the one to detect the hip rotation. So you will do hip rotation. As you see, this is called internal hip rotation. Despite that the foot is out, the hips are looking inward. So this is you're checking the hip internal rotation by bringing the foot outwards, because that will bring the thigh inward. And if you see, you have to do that in both sides in the same time, so you're getting the movement in the hips and not through the pelvis or the spine. And then you do external rotation. External rotation, you bring the foot inwards, and you see when you bring the foot inwards, the thigh comes outwards. So this is you're assessing the hip internal rotation. This is you're assessing the hip external rotation. You see the marked difference between the amount of internal rotation is about 70 degree, and external rotation is less than 30 degree. This is another example of excessive femoral anteversion. This is a 12-year-old female coming with her parents complaining of intoeing. You see once she lies prone on the bed, her both feet are turned inward. So we do the second step in the assessment of rotation, which is assessment of hip movement. You see when we do the hip internal rotation, she has about 90 degree of hip internal rotation. When we do hip external rotation, she has only about 10 degrees of external rotation. I'd like to emphasize again on how you do the test. You see this is a hip internal rotation. When you bring the feet outward, you actually bring the hips inward, and this is assessment of hip internal rotation. So in this case, she has about 90 degree of hip internal rotation. And when you bring the feet inward, you're actually bringing the hip outward. So in this case, she has about 10 to 15 degree of hip external rotation. And as you see, we do both sides together, so you make sure you're getting your movement from the hips and it's not coming from the spine or the pelvis. So what is the treatment of femoral anteversion? No treatment is required. So as we said, this is a self-limiting disease. The vast majority of the kids will improve by themselves by the age of 8 years. So you have to reassure the family, telling them that the natural history of this disease is most kids will improve with time, and usually by the age of 8 years they will have their normal anteversion. They will ask you usually about bracing and orthotics, and all the study shows that bracing and orthotic do not change the natural history of this condition. So if the child is going to improve, he's going to improve by himself. No need for bracing or orthotics. So again, to summarize, the vast majority of cases do not need treatment. You have just to reassure the family, telling them about the natural history, and telling them that most kids, the vast majority of kids will improve by the age of 8 years. If the condition persists beyond the age of 8 years, you can do orthopedic referral, and surgery to external rotate the femur is rarely indicated. So this is a child with internal rotation. She's on the, as you see on the OR table, she was 13-year-old. She had a severe degree of excessive femoral anteversion. She was one of the few that did not improve. So what we did is we go there, we do osteotomy of the femur, which means we break the femur, we rotate it outwards, we fix it with plate and screws or with nail. In this case, we fix it with plate and screws, and if you see the improvement on the table after the surgery, you see here the dressings of the surgery side. So this surgery to external rotate the femur is very rarely indicated. As we said before, the vast majority of children will improve. You always reassure the family, telling them that most children will improve by the age of 8 years, and only if they don't improve by the age of 8 years, refer them, and if they are interested, we can proceed with the external rotation osteotomy. So the second cause of intoeing is internal tibial torsion. We'd like to first discuss what is the definition of internal tibial torsion. Internal tibial torsion means inward rotation of the shaft of the tibia. That means that the tibia is turned inward, and it is considered normal finding in newborn due to intrauterine position. So all newborns, when they are born, they have internal tibial torsion due to the position of their legs intrauterine. And internal tibial torsion is the commonest cause of intoeing. It's the commonest cause of intoeing in general, and it's by far the commonest cause below the age of 3 years. So let's see the examination of a kid presenting with internal tibial torsion. So again, you will do the first and the second part of the assessment of rotation, which is the foot progression angle. So you will ask the child to walk, and you will see that his foot are turned inward, and then you will do the hip internal rotation, external rotation. In this case, it should be he should have equal or near equal internal and external rotation, and then you continue with the third and the fourth steps of the assessment of rotation. So the child is prone. You see it's a younger child because internal tibial torsion is more in children less than 3 years old. And then you assess the relation of the foot to the thigh, because this gives you an idea about the tibia. Remember, the tibia is the connection between your thigh and the foot. So when you assess the relation of the foot to the thigh, you're actually assessing the rotation of the tibia. So in this case, you draw a line along the axis of the foot, and the line draw an axis of the thigh. Of course, that's an imaginary line, and you will see that the foot is pointing inward. Instead of having normal 5 or 10 degrees of external rotation, that's the normal tibial torsion, you have here about 30 to 35 degrees of internal tibial torsion bilaterally. So after we discuss the diagnosis of internal tibial torsion, let's speak about the treatment of this condition. It's very similar to the treatment of excess femoral anteversion. No treatment is required in the vast majority of cases. This condition is self-limiting. Usually the kids spontaneously resolve within the first few years of life. Again, bracing and orthotics do not change the natural history of the condition. So you have to reassure the family that most kids by the age of 4 years, their tibia has the normal rotation. Only if the conditions does not improve by the age of 4, orthopedic referral is warranted. And the surgery to externally rotate the leg is rarely indicated. Now let's discuss the third reason for intoeing, which is metatarsus adductus. Sometimes it's referred to as metatarsus varus. What is the definition of metatarsus adductus? It means that a deduction and inward position of the forefoot in relation to the hind foot. So if you see, this is a child foot. If you see the forefoot, which is the anterior part of the foot, is inward, is pointing inward in relation to the hind foot, which is the posterior part of the foot. So the forefoot, which is this part, is positioned inward in relation to the posterior part of the foot, which is the hind foot. So what is the clinical presentation of metatarsus adductus? The clinical presentation will be a child with intoeing, as we discussed before. When you examine the child, as we said, for the assessment of the rotational malalignment, in the last stage you'd like to assess the relationship between the forefoot, the anterior part of the foot, and the hind foot. So if you draw a line bisecting the hind foot, normally this line should bisect the foot in the second toe or in between the second and the third toe. However, if this line bisects the anterior part of the foot lateral to the interval between the second and third toe, that tells you that this child has metatarsus adductus. So if you see here, this is the fourth stage of assessment of rotation. As we discussed before, the first one will be assessment of the foot progression angle, and then the second, third, and fourth will be done while the child is in the prone position. The second one is to assess the hip range of motion. The third one is to assess the thigh foot angle, which is the relationship of the foot in general with the thigh, which represent the tibial torsion. And then finally, the fourth one is the assessment of the forefoot to the hind foot. So we draw a line bisecting the hind foot, and we see where is this line going to bisect the forefoot. So if you see here in this example on the right side, it bisected the forefoot between the fourth and the fifth toe. That tells you that this is a severe form of metatarsus adductus. In this and the left side, it bisected at the stage of the fourth toe. That tells you it's a moderate metatarsus adductus. Remember, this is done with the child in the prone position. This is a diagrammatic representation of the metatarsus adductus. So the child will be in the prone position, and then you will draw a line bisecting the hind foot, and you will see where this line is going to bisect the foot. So if it bisects in the third toe, that's mild metatarsus adductus. the fourth is moderate, and in the fifth, that's severe metatarsus adductus. And if you see, when you examine the child, he will have a curved lateral border. So in normal, you should have a straight lateral border. If the lateral border of the foot is curved, as we see in this example, or as we see here and here, the curved lateral border, that tells you that this child has metatarsus adductus. Remember, when you see a child with metatarsus adductus, these conditions may be related to uterine malposition. So other conditions related to uterine malpositions like hip dysplasia may be associated. So you have to examine the child very good regarding his hips to make sure that this child does not have hip dysplasia. Someone may ask, how can you differentiate metatarsus adductus from clubfoot, which is much more severe condition? Remember, in the clubfoot you have to have ankle equinus. However, in metatarsus adductus the ankle is normal. And also in the clubfoot, the hind foot is inverus. It means that the posterior part of the heel is pointing inward. However, in the metatarsus adductus, the hind foot is normal. Remember, the metatarsus adductus is a problem of the forefoot. So the forefoot is pointing inward in relation to the hind foot. So the hind foot is normal. However, the forefoot is pointing inwards. That will cause, as we said, intoeing, will cause curved lateral border, and may be associated with other conditions of uterine malpositions like hip dysplasia. So what is the treatment of metatarsus adductus? As we said in the two conditions before, the excess femoral anteversion and the tibial torsion, that these conditions usually improve with age. So most of the cases with metatarsus adductus also would improve without interference. So observation is warranted for the 6 months of life. If by 6 months of life the condition is rigid, it's not correcting, I would do an orthopedic referral, and the orthopedic surgeon will either do casting or bracing. Surgery is rarely indicated. Sometimes with metatarsus adductus we use what's called straight last shoe. So if you see, this is a normal shoe, normal right shoe. So you see the inner aspect of the shoe here is the normal aspect of the shoe, which is curved in this way. The straight last shoe, so this is a left side shoe, has a straight last from inside. So it's actually, instead of the foot pointing this word, it pushes the foot to the other side as a form of correction. Again, most of the cases of metatarsus adductus does not need referral. They don't need interference. Most of them will improve by themselves, and referral to orthopedic surgeon only if the condition does not improve after 6 months of life. Thank you very much.